On today's episode of Real Life Pharmacology, I'm going to cover the SNRIs. So these are the serotonin and norepinephrine reuptake inhibitors. Now, the common examples that I see in clinical practice are duloxetine, which brand name is Cymbalta, and venlafaxine, which is brand name Effexor. There are a couple of others out there that are classified as SNRIs. Desvenlafaxine is another one, which is Prestique, and also one or two others. Very seldom do I see them used, simply from a cost-effective standpoint. The duloxetine and venlafaxine are generally much, much cheaper, but you may see those other ones on rare occasion. So these drugs, what are they used for? Serotonin and norepinephrine reuptake inhibitors, or SNRIs, are typically used for depression and or various pain syndromes. Classic examples being neuropathy. You may see fibromyalgia, these drugs being used for that. Migraines, on a rare occasion you might see that. Anxiety is another psych condition that you may see these medications used for as well. One other unique use that I've definitely seen venlafaxine used for is menopausal symptoms. So patients who have hot flashes and things of that nature, night sweats, associated with menopause, it may be a non-hormonal type medication that may help with some of those symptoms. So the mechanism, the way these drugs work, is they increase serotonin and norepinephrine in the brain, and they do that by inhibiting the reuptake within the synapse. So again, increases serotonin, increases norepinephrine. The pain component is always taught and associated with that norepinephrine effect compared to SSRIs, which generally only target the serotonin reuptake inhibitor. So again, a little bit maybe more benefit and proven benefit in various pain syndromes like nerve pain, neuropathy, and things of that nature. Duloxetine does probably have a little bit better evidence as far as its relief of pain and use in pain management. With that said, the serotonin activity of Effexor at lower doses is stronger, but if using venlafaxine or Effexor for pain syndromes, generally we've got to push the dose up and get to higher doses to potentially see that beneficial effect. Now, the higher you go on dosages of medications, the more likely you are to encounter side effects as well. But I would say in practice, I definitely see duloxetine probably used first and foremost ahead of venlafaxine if we're treating any type of pain condition that we want these medications to help with. On the side effect front with these medications, I would say it's pretty general for the most part. GI upset, stomach upset, nausea, vomiting, things like that can happen. I would say they're not crazy common, but certainly if you start a new SNRI, you may see some of those issues. I've seen it go both ways with sedation and insomnia. These drugs can kind of maybe cause either. The insomnia maybe is a little bit more part of the norepinephrine type effect. So again, you might see either of those. I've definitely had patients report significant fatigue on these medications as well. So kind of up in the air on that sometimes. Sexual dysfunction. So those drugs, SSRIs, can cause sexual dysfunction. SNRIs are in the same boat there as well as far as that goes. You may see other vague, nonspecific things, CNS changes, dizziness, confusion, potentially more likely in our geriatric population, but overall, generally fairly well tolerated. Of course, these drugs do act on serotonin, so serotonin, however low it might be, serotonin syndrome is a potential risk with these medications. I did want to talk a little bit about discontinuing these drugs, and more specifically, discontinuation syndrome. I can't recall offhand if I talked about this in the SSRI section, but this can happen with SNRIs as well. I have personally seen it with venlafaxine. If we discontinue that drug abruptly, the body tends to maybe not react to that quite as well as we would like. And with that discontinuation syndrome, you may see some dizziness, you may see some headaches, some fatigue, some GI upset, anxious, those type of feelings as well. So it can be really disconcerting and really uncomfortable for our patients. So with these meds, that's generally why we try to taper off slowly. And, I always say that if you're going to slowly taper up, if we don't have serious adverse effects and you want to get off the medication, why wouldn't we try to slowly taper down as well? It's the safest and best way to do it. Again, as long as there's no, life-threatening considerations that we need to take in account. So start low and go slow. I think that applies to both going up and going down in general with these medications. And one of those big reasons is this discontinuation syndrome that can happen within a week or two of stopping the medication, particularly if we go from a moderate to high dose to nothing. I hope you're enjoying the podcast, reallifepharmacology.com. Go check out our parent company, meded101.com/store for more premium content, particularly for you exam takers, for pharmacist certification like BCPS, or for students as well regarding the NAPLEX. We've got some materials there that we think are really practical, really useful, and will definitely help you prepare to pass your exam. So meded101.com/store. Go support our sponsor. And now I wanted to get into drug interactions with the SNRIs. And I would say when I think of drug interactions, I don't immediately think of the SNRIs as having a million drug interactions, but there are some that I think you need to think about. And certainly if you have any questions, you definitely need to double check and look these drugs up for sure. So first one that I definitely wanted to cover was the serotonin additive effect. So triptans, tramadol, other SSRIs, all those type of medications, if they've got additive serotonin type effects, that could potentially increase the risk of serotonin syndrome. So definitely remember that with this class of medication. One interaction I know I've seen in practice, bupropion is a CYP2D6 inhibitor, and this can actually increase concentrations of venlafaxine. So let's say you have a patient and you start on bupropion. There is the potential, if the patient experiences adverse effects, maybe they're more anxious or jittery or tremor or something like that, or GI upset, there is the potential that it could be from elevated venlafaxine concentrations versus the bupropion drug itself. So by bupropion inhibiting CYP2D6, that can increase concentrations of venlafaxine. And this can certainly happen with other CYP2D6 inhibitors as well. It's just a common real-life pharmacology example that I've come across. 3A4 inhibitors, strong 3A4 inhibitors, can potentially increase those concentrations of venlafaxine as well. Kind of the classic systemic example I think of are the azole antifungals like ketoconazole, for example there. Now duloxetine, again the other common SNRI, this actually inhibits CYP2D6 itself. So one example I've seen in clinical practice that we should avoid is using duloxetine with tamoxifen, which is used in the prevention of breast cancer. Tamoxifen is actually a prodrug and activated to active metabolites by CYP2D6. So by blocking that, like duloxetine can potentially do, you would get a reduced level of those active metabolites and reduced effectiveness of tamoxifen. So this obviously could lead your patient to maybe be at increased risk of developing or redeveloping breast cancer if we're using tamoxifen in that patient. So just a few drug interactions that I think you should be aware of anyway. Again, if you've got questions on other drug interactions or you're looking at a big medication list, I'd strongly encourage people to look that stuff up and do a drug interaction screen and see if there's anything clinically significant. It's what I do in my clinical practice if I'm not sure, if I'm not comfortable with something there. So that sums it up for today. If you love the show, leave us a rating, review on iTunes. Greatly appreciated. If you've got comments, questions, concerns, certainly reallifepharmacology.com and hit the contact button. And you can certainly shoot me personally an email. So Eric Christensen, pharmacist, signing off for today. Thanks for listening. Take care and have a good rest of your day.